So now circulating DNA is mainly used in non-small cell lung cancer. For patients at time of diagnostic, we have no biopsy available, for example, and also for patients that presented an EGFR mutation that are currently treated with EGFR inhibitors, but as recurrences. And for those patients, it's necessary to look at a resistance mutation, for example, the T790M mutation, in order to change their treatment to another TKI inhibitors called Tagrisso, a third generation of TKI. So the main use of ctDNA is in non-small cell lung cancer. But there are also different indications. We can use also ctDNA to look at the response to treatment at the beginning of the treatment. We can also use it for the detection of early recurrence. And there is some data showing that ctDNA could detect a recurrence at least 6 months before imaging, so that's very important. And at least we can use also, as I said before, the detection of resistance mutation. This is true in non-small cell lung cancer, but this is also true in ovarian cancer, for example, for the detection of BRCA2 reverse mutations that reverse the inhibition of the initial primary BRCA2 mutation. And in this case, olaparib is not effective at all. And for example, another example could be also in metastatic breast cancer, and sometimes it can appear some mutation of PI3 kinase or mutation in the gene ESR1, and those mutations are related with a lack of efficacy of anti-hormonal treatment. But now for these patients there is a solution, because they can move to another treatment like palbociclib, for example. So they can move for another treatment like palbociclib and fulvestrant. Soon I believe that ctDNA will be used in clinical routine in cancer like metastatic breast cancer for treatment, for example, by olaparib, but maybe also for immunotherapy. It could be used also in colorectal cancer in order to detect EGFR extracellular mutations and to define a subgroup of patients that can respond very well to anti-EGFR therapy. That's the patient we call triple negative, with no mutation on KRAS, on BRAF and EGFR extracellular domain. And I expect that it will be in the next future, and not very soon, but we expect to get tests for screening patients, especially patients who are at risk of cancer.